Hello, everyone. My name is Dr. Elena Joerns. I'm talking to you from Rochester, Minnesota. Today, we will talk about biomarkers in interstitial lung disease, or ILD. So before we begin, I do want to make it clear that we'll talk about blood-based biomarkers. There's a lot of interest in radiomics and biomarkers based on the radiographic appearance, but we're not going to touch on them today. And we're not going to talk about biomarkers in bronchoalveolar lavage fluid, although those are very interesting. So there has been a lot of interest in biomarkers in the last couple decades. So you're going to see a lot of studies on those. I confess I have a couple of those out there myself. And biomarkers in ILD have gained so much interest because people are trying to figure out how to diagnose ILD and how to determine which patients with ILD will progress and which ones won't. So there have been many ways for people to try to figure it out. So you'll see studies with proteomics, metabolomics, genomics, all sorts of omics you can imagine. And most of them are really not panning out to truly be clinically useful yet. And I think a big drawback for those studies is that a lot of those patients with ILD that they're studying, particularly for diagnosis purposes, they're not necessarily validated. So we're not ever entirely sure, are they truly autoimmune ILDs? Are they truly having the diagnosis that the researchers are thinking they do? So I want to talk to you about a few biomarkers that might actually be useful for you in your everyday practice in your rheumatology clinic. So first, some of the biomarkers that might come out of the research world that you might start seeing and that you might be seeing already in studies as sort of like an exploratory endpoint are KL6, Krebs von den Lungen 6, and SPA and SPD, surfactant protein A and D. So those biomarkers seem to be correlating with fibrosis in a variety of ILDs. They seem to be doing a little bit better in non-autoimmune ILDs based on a recent meta-analysis. But regardless, they might be useful and they might be coming to the lab near you. So which biomarkers do I use? So my clinical and research interest lies predominantly in interstitial pneumonia with autoimmune features, or IPAF. So biomarkers are a huge part of my practice and a huge part of how I view those patients. So a panel that I check on every patient with ILD that comes through my door is myositis antibody panel. Myositis antibodies have a great importance in patients with ILD. Particularly in patients with IPAF, myositis-specific antibodies, such as anti-synthetase antibodies, MDA5, SRP, TIF1 gamma, they have been shown to really give a very similar behavior to the ILD as defined myositis ILD. There was a study that looked like at IPAF with MSA versus IPAF without MSA and various types of autoimmune ILDs and also idiopathic pulmonary fibrosis, or IPF, and found that IPAF with MSAs behaved very similarly in terms of response to immunosuppression and survival as myositis ILD. So definitely, if somebody has ILD, no features of myositis, but has PL7, PL12, I will be immunosuppressing them because those seem to be quite an inflammatory type of interstitial lung disease. Another biomarker that I check routinely on all of my patients is SSA52 or Rho52. Rho52 has been consistently shown to be associated with poor prognosis in a variety of ILDs. It has been shown to be associated with poor prognosis in scleroderma and even in IPAF and idiopathic pulmonary fibrosis and other autoimmune ILDs. So if I have somebody with positive SSA52, I'm just a little bit more nervous about the course that their ILD is going to take. So I might be checking their pulmonary function test maybe a little bit more often and checking on them maybe a little bit more frequently. My favorite test that I want to talk to you about are telomeres. So telomeres, if you remember, are those little things, there's 6 nucleotide repeats on the ends of chromosomes that maintain the chromosomes, and they shorten with cellular replication and aging. Turns out that short telomeres predispose you to having pulmonary fibrosis or interstitial lung disease. It has been seen in idiopathic pulmonary fibrosis, and now we are seeing that it is true in autoimmune ILDs as well. So if somebody has short telomeres, you always wonder, is it due to some sort of effect of toxic chemicals? Is it due to their age? Or is it due to a genetic variant that causes premature shortening of the telomeres? And telomere biology disorders can give you pulmonary fibrosis, but can also give you things like liver cirrhosis, early graying, blood dyscrasias, and you can see it in a variety of ILDs, again, in autoimmune ILDs, in idiopathic pulmonary fibrosis, and unclassifiable ILDs. So I see a patient who has early pulmonary fibrosis or tells me they have early graying or have family history of pulmonary fibrosis. I'll be checking their telomeres. If they have short telomeres, I know these patients are not going to do well. Short telomere lengths, and when I say short telomere lengths, it's peripheral leukocyte or granulocyte telomere lengths. Those patients have poor survival, increased need for lung transplant, and worse response to immunosuppression. More on that later. So those patients, I might be referring to lung transplant earlier, and I might be watching them very, very closely. Also, telomere length matters for the choice of therapy. There has been a study of non-IPF ILDs where the authors looked at leukocyte telomere lengths and looked at the effect of immunosuppression. And they found that those with short telomeres actually did worse when they were exposed to mycophenolate and or azathioprine. And they were looking at SARD ILDs, systemic autoimmune rheumatic disease ILDs. They were looking at hypersensitivity pneumonitis, and they were looking at unclassifiable ILD, IPAF, probably. They really found a significant association in hypersensitivity pneumonitis and unclassifiable ILDs, probably because they didn't have enough patients with short telomeres in the SARD ILD group. So I wonder if they had more patients. There might have been a significant correlation there as well. Still, if I am worried about a patient, I will be checking their telomere lengths before I ever start mycophenolate or azathioprine. And here in Rochester, Minnesota, we check telomere lengths by using FlowFish. I know it is not available everywhere, but I think with increased awareness, increased ordering, increased interest, it is going to be more available in the future. Thank you so much for listening. It's been a pleasure talking to you today. Until next time.